slides clear? Can you see my slides?
Yes, I see your slides.
Okay,
Go
thank
ahead.
you, Dr. Sam.
You're welcome.
A good day to all the attendees today. Getting early in the morning of a Friday just to hear science. I applaud you for all of this, and may this conference be a very fruitful and scientific conference for you. So what I'm discussing today is what every pediatrician knows already, and I'm just highlighting some tips and tricks on monitoring of the growth and how that we can early detect growth abnormalities to prevent children from the huge consequences of malnutrition. This is our mission. Our mission is optimum growth. To just the journey from childhood to adolescence to pass smoothly without any problems, without any growth abnormalities, because we know that the impact is huge. We need optimum developmental, cognitive, psychological, and behavioral development for all our children. So growth is a dynamic process. It is increase. It starts intrauterine. From the first 1,000 days, increase in the physical size, rapidly dividing cells, hundreds of millions of neurons each day for the brain development. It's associated with increase in the cell number and cell size. And we have three major components of growth. So children's growth is ongoing. It should not be stopped. So I cannot have a mother coming to me in the clinic telling me that my child did not gain weight for 2 or 3 months, or my child did not gain height for the last 6 months. So this is not acceptable in children. So it's ongoing. It is normative and expected. We have expectations. We know that a child at birth of 3 kilograms would have an expectation of weight. We have centiles. We have Z-scores. So we have expectations for children growth. Once they deviate from these expectations, we have to stop and reassess our children. And there are a lot of growth patterns. It's only not physical growth. We know that physical growth is characterized by two huge spurts. The spurt in the first 1,000 days in infancy, in the first years of life, and the spurt in the adolescent years. But we also have the growth of the brain which is completed at the age of 85% of brain development is completed at the age of 3. Total brain growth development is completed at the age of 5 years. As we can see here, this curve of the brain development. We have the general development, which is a physical growth spurt at first, then the growth velocity decelerates a little bit or increases gradually. And then we have another physical growth spurt. We have the reproductive growth spurt, of course, that happens in the adolescent years. So what are the components of growth, or what affects growth of children? Genes, of course, but to what extent does gene affect the growth of our children? So if I'm having apparently short parents, does this mean that the child has to be short, or maybe he's shorter, maybe he's taller? No, we have the environmental effect also, social, psychological, the impact of the environment, the social impact of the environment on the child affects the growth. Yes, definitely. We have the hormones, of course, socioeconomic status, and of course, nutrition is a major player here, and the stimulation that the child gets all through his life affects the development and cognitive skills and behavioral skills, and the presence of infection or repeated infection definitely has a huge impact on growth. So as I believe this is an endocrinology conference, so we're discussing a lot of hormones all through the scientific program, and we know that the hormones are really important. They have a major role in the growth of our children. The big player here is the growth hormone for the body tissue and DNA synthesis and cell duplication. So any affection in the growth hormone would affect the overall growth of the child. We have, of course, the thyroxine, which is important for the brain development, early brain growth, the metabolism, the bone growth as well, and the cell size and duplication. And we have the testosterone and the androgens and the estrogens, which help in the pubertal growth spurt. Regarding the height, because this is a major issue when we are following the growth of our children, and we have a lot of malnutrition rates regarding stunting in our country and in the region. So linear growth is determined by cell proliferation, and we have two major hormones controlling this proliferation, the growth hormone and the IGF-1, which is critically important for the epithelial and the longitudinal bone growth. So are our genes our destiny? This is a debatable question that a lot of research has a lot of impact in it. And this is Gluckman 2013, stating that we have limited genetic influence on the growth of children, maximum around 20%, and 80% is actually driven by the environmental factors. The major environmental factor is the nutrition. Of course, the exercise, the infection, the heat, the stress, and the social environment of the child. So if 80% of the growth of the child, the brain development, the immune development, and the metabolic development actually is driven by the environment. And this is a very nice graph to illustrate this. This is from WHO Multi-Center Growth Reference. And this study revealed that infants and children with different ethnic backgrounds, whether they are from Africa, from Asia, or from Europe, they grow very similar speed when the environment is just similar. Irrespective of their genetic background or ethnicity, if you put the child in the optimum environment for growth, so the growth potential in Brazil, in Ghana, in India, in Oman, and in California, they are all the same. And this highlights the highest importance of the environmental factor on growth. So it's not nature or no nurture. Actually, it is both combined. And the genotypic height attainment requires nutrition and stress-free, hygienic, nurturing environment for optimum growth. This is the genetic potential. If I'm in a good environment, I will reach my genetic potential regarding height velocity, regarding weight velocity. If I'm in a less or a poor environment with malnutrition or a less ideal environment, I will have deceleration in the growth and I will maybe develop malnutrition, or I will not reach my full genetic potential. So malnutrition comes in many forms. If we don't have optimum growth, optimum environment, optimum nutrition, the genes are working, hormones are working, we are faced with a lot of different types of undernutrition, mainly wasting, which is a low weight for age, stunting, low height for age, underweight, and nowadays we're having the hidden hunger, which eventually deficiency of vitamins and minerals that has no visible warning signs. And the impact on growth is detrimental because it will affect growth, it will affect the velocity of height, it will affect the velocity of weight gain. And we're still faced with an alarming number of malnutrition all over the world. I'm not discussing millions here because we are faced in the region, in Africa, in the Middle East, with a burden of stunting, with a burden of wasting, with a burden of even obesity or micronutrient deficiency. 7 million of children will lose their fight against hidden hunger every year. These children are on the verge of increasing always morbidity and mortality. So they lose their fight with just the lack of vitamins and minerals and the hunger that we did not detect in the follow-up of our children. We know that malnutrition have a short-term impact and a long-term impact on the child's health. Short-term, decreased immunity, increased risk of infection, decreased wound healing. These children are the children who enter the hospital with extended length of stay. They don't improve as they should be. The high morbidity and mortality rates, and we have a long-term impact on the brain development, delayed neurodevelopment. The cognitive scales are less. The behavioral issues are more among these children, and this is detected in the primary and secondary school, decreased immunity, even programming, because if we don't have the right nutrition at the right time, the optimum growth trajectories in the first years, we are going to have a programming of cardiovascular disease, obesity, and diabetes later on. We know as pediatricians that the first 1,000 days are golden 1,000 days, as we say, that the right nutrition at the right time provides optimum growth, provides optimum programming for an adult, a healthy adult with no cardiovascular disease, obesity, or diabetes. And we know, moreover, we know that the deficiency in the first 1,000 days is irreversible. Once there is deficiency, once I did not monitor growth properly, the child is having any of the malnutrition problems, the effect, whether it's short-term or long-term effect, is irreversible. He already paid the price from cognitive development, from immune system development, or from his health overall. So the lifetime cost of stunting is increasing in mortality in our population. IQ scores are less. Consequently, income is less. And this translates into money and economic burden on the countries. I like this map. I call it the nutrition map, because every pediatrician should be aware of a sensitive period where there is a nutrition vulnerability, what are the velocities that he should gain in every stage, what are the nutritional needs in every stage, and what are the feeding problems in every stage, because 90% of growth abnormalities or faltering growth in children are of non-organic type, and non-organic type is really detected by a good history and assessing the needs and understanding the feeding behaviors in every stage, whether it's as a toddler, the lack of diversity or low feeding frequency, or eating a lot of junk or consumption of a lot of junk, whether it's in school age children where they need physical exercise and it's not there, and the consumption of junk food, the physiology, or as we say, the behavior of the feeding and the eating is really built well, as long as we go from infant to childhood to adolescent. So this is why prevention is better than diagnosis. This is why growth, monitoring growth, optimum growth is our mission as physicians, as pediatricians, as endocrinologists. This is the aim and this is the goal that we are aiming for. So prevention, we should do screening tools. We should have our screening tools to prevent the occurrence of malnutrition, whether you're choosing the Strong Kids screening tool, the STAMP, the Pediatric Cure Malnutrition screening tool, you should have a screening tool, or whether it's the ASPEN, which are 5 really basic questions in your clinic for the detection of or for the screening of malnutrition, especially in at-risk population like premature children, picky eaters, children with chronic illnesses, children with psychological stress and environmental impact. So the first thing in the pediatric nutrition assessment for normal growth is a good medical history. A good medical history, anthropometry, nutritional focused physical exam, ordering the appropriate lab and behavioral assessment. So we screen, as we said, there are a lot of tools. Use whatever is the easiest and the simplest for your clinic or for your hospital, but you should have a screening tool. You should detect these children early for prevention. In children with repeated infections and where in the winter or in the summer, chronic disease, physical disabilities, hospitalization, dietary restrictions, children with CMPA, children with inflammatory bowel disease, children on elimination diets, they are at high risk of malnutrition and growth problems later on. So detailed history is the golden rule. You have to take a detailed history from the perinatal history to the nutrition history, detailed 24-hour recall, 3-day food diary are tools that would direct you to what is the problem. Is he not taking enough? Because we're having an algorithm when we are facing with a growth abnormality. You have the first step is to assess the intake of the child, the family, how is the family, the genetic potential, and if there is any medical history denoting an organic cause of this growth abnormality like diarrhea or constipation or spitting or whatever. In weaned babies and children, please take a detailed history of the liquid they are consuming, of the milk, of the juice, of the mealtime, if the family mealtime. All this will help you in putting the child on the way regarding the nutrition. Then we have to take a detailed anthropometric measurements and plotting good anthropometric measurements, weight, height, weight for length, mid upper arm circumference, head circumference. And the key is standardization, because grams and centimeters can change the decisions you are taking towards this child. So a child can have a growth velocity on the non-normal centile, and if you just missed a few centimeters, it can be below the centile and the decision would be different. So standardization of the equipment, we have to use stadiometers and femtometers for length and height, and we have to use a calibrated digital scales. We have to standardize the technique. So I don't weigh a child except that he's minimal clothing, or I don't, I have a technique of the height attainment. So standardization is the key for better decision-making later on. This is the infantometer. And by the way, just measuring the length or measuring the height, they have educational videos done by the WHO or on the optimum technique, because the length, for example, cannot be taken by one operator. It needs 2 operators, a doctor and a nurse, 2 doctors, whatever. So these standardized techniques, they help in the process of growth monitoring and taking proper decisions for these children. And the frequency of monitoring, if I'm having any growth abnormalities, definitely I will follow up this child more closely. So if I'm having faltering growth, the growth is not optimum, maybe I will follow, in the first month of life, I will follow the child daily. in the first 6 months weekly, in the second 6 months fortnightly, every 2 weeks, above this monthly. If this child is not gaining the appropriate weight or the appropriate length, so I am having a close monitoring of this child. And the choice of growth charts, of course, affects my decision regarding growth in children. So we're having a lot of growth charts. We're having the CDC, we're having the WHO, sometimes specific populations like the UK growth charts, they have growth charts of their own. We have Egyptian charts. So the choice of charts should be standardized and referenced. So we have Egyptian charts that they were not updated or referenced so far. So we are using the standard in Egypt, the WHO growth charts. You cannot use the CDC for growth monitoring and evaluation in the first 2 years of life, as per CDC themselves, because it was not cross-sectional, it was not on all over the countries and the continents. It was done in one continent, and it was done on a hybrid of children, formula-fed and breastfed. So they are not optimum for monitoring growth in the first 2 years of life. So WHO is mandate. As even on the CDC website, they download the WHO charts for the first 2 years of life. So WHO is mandate for the first 2 years of life. You can monitor later on using the WHO. You can use the CDC above 2 years of age, especially in the BMI and the assessment of overweight and obesity. Interpretation of growth charts is really of utmost importance. Why? Because if you are having a child that is having low weight for age and the height and head circumference are appropriate, think always a nutritional cause. Take detailed history regarding the nutritional intake. If you're having a child who is affected more regarding the height or length more than the weight, so think of endocrinal cause of growth abnormalities or a skeletal deformity maybe. If you're having a child having the weight, height, and head circumference all below the centiles, all below the third centile, all below -2 standard deviation, think chromosomal, metabolic, or severe malnutrition. So just assessment of the growth charts and proper interpretation of my measurements would direct me to further to what is the cause of this growth abnormality. So the measurements have to be standardized, use the appropriate growth charts, and interpret the growth charts as needed. So the use of z-scores, I'm always faced with the questions, why use the z-scores? The percentiles are enough. We follow our children with the percentiles. So the z-scores are the malnutrition diagnosis. We need the z-scores for more accurate assessment of malnutrition. We can use them for the cutoff and the decision making. The third centile is equivalent to the -2 z-score. But any height, for example, below -2 z-score should be evaluated. If less than 2.25, it should be referred to an endocrinologist. So just having the z-score provides you with better prognosis, better follow-up of your patient, and better decision making regarding the height of the child. And disease scores, as much as they seem to be a hassle, now every a pediatrician have an application on the mobile, on their laptop, on their desktop, how to put just the weight and height of the child, and there is a z-score automatically appears with the percentile. So what are the diagnoses that there is apart to deviate from the normal growth? This is the WHO key. So the green boxes are the normal. Below -2 for height is stunting. Below for weight is underweight. Below for weight for height is wasted. And we have the other side, the above one is the possible for BMI and weight for height, possible risk of overweight, above 2 overweight, and above 3 is obesity. So this is the malnutrition diagnoses as per WHO. You can use the Aspen, and I like the Aspen because they don't just depend on one reading, they depend on multiple readings. So if the child is having weight loss 5% than the usual, you have to have 2 points or 3 points at least, or 7.5%, this is moderate malnutrition, more than this is severe. The velocity is not accepted. We detected early, so this is mild malnutrition, less than 75% of the norm. Moderate is less than 50%. Even the nutrient intake, if you are assessing the nutrient intake of the child and he's taking 50 to 75% of the estimated energy needs, this is mild malnutrition. So this is where you need to intervene. This is where you need to detect the child to put him on the right track and provide optimum growth later on. And BMI is a really good indicator of the child nutritional status, but beware, because sometimes we are faced with a BMI, a normal BMI child. But when we take a history, this child has a chronic energy deficiency over a long period of time that affected the height eventually. So if we're having a child with a chronic energy deficiency that affects the weight and consequently the height, so this child will have a normal BMI. This is not a normal child. You have to detect this by taking good history and examination of the child. So sometimes BMI could be tricky. So what is faltering growth? This is the diagnosis of malnutrition. Faltering growth is a sign that you will not detect unless you are having growth charts, growth monitoring of your child, and it is experiencing a slowing of the expected weight velocity or height velocity over time. So we have the big definitions, the fall across two or more weight centile spaces, or the weight or height is less than a third, or is below the expected range, or the BMI is less than the third centile. All these are definitions that just indicate that you are following this child and the growth monitoring, and he's not gaining the velocity, he's not within and parallel the growth charts, and there is stagnation of growth. There is plateauing of growth. And the first thing that we said about growth is that it should be ongoing. So it is not accepted for any visit, the child that you are following, to stop the growth. Once you have one visit, two visits with weight, the child not gaining weight, the child for 6 months not gaining, for 3 to 6 months not gaining height, this is an alarm that you should be stopping and assessing this child fully. And the causes mainly, as we said, are non-organic, 95%, organic, 5%, and the organic causes vary. According to the caloric intake, maybe the child is having an anomaly, a GERD, a chronic infection, inflammatory condition, congenital heart disease. The needs are higher than the intake, or the child is having something regarding absorption of the GI. He's taking enough, yes, the nutrient intake is enough, but he's not also gaining weight, like the Gamal protein allergy and the celiac disease. And these, we have to focus on them because they are in the algorithm of the child not gaining enough weight and height. Pancreatic insufficiency of core, liver disease, and IBS. Other diseases like hyperthyroidism, beware that some populations, they have a specific growth potential like Down syndrome and the CP, they have growth charts of their own. The timing of the growth abnormality also may have a clue. The time of faltering growth may have a clue. It starts at birth. Think of anatomic abnormality, infections, or congenital syndrome. If it starts after 1 week or 2 weeks in the first month of life, revise the breastfeeding. This is suspicious of breastfeeding dysfunction, cardiac anatomy, inborn errors of metabolism. At 1 month, suspect cystic fibrosis or inborn errors of metabolism. 1 to 6 months, protein sensitivity, cow milk protein allergy, RTA. 6 months, celiac disease, because we introduced the gluten. 9 months, inappropriate diet. The child is not receiving diversity and is not gaining the appropriate feeding behaviors. And at 1 year, of course, it is mainly on organic intolerance to food, the child mother dyad, the problems of the feeding difficulties, they all start to appear at the age of 1 month. So the non-organic causes are in the child and in the family. Revise this by the history. The child may be having sensory aversions, hypersensitivity, super tasters. Maybe he's not sleeping well, because we know that sleep is important for optimum growth hormone production and for optimum metabolism at the end of the day. So if he's not sleeping well, revise this with the parents. Family factors, of course, because environment has a huge impact. If the parent is having poor parenting skills, or there's neglect or abuse, or environment is not optimum, it will affect the growth eventually. Nutrition-focused physical exam is a skill that you need to be trained on, because you have to look closely at your patient to detect any abnormality, any signs of vitamins or mineral deficiency, maybe a change in the hair color, or a change in the hair texture, or falling of hair. Maybe you can have edema or muscle wasting. You have to look at the child regarding his face, his clavicles, his ribs, his scapula, and if there are any bony prominence, this is muscle wasting. You have to look at the skin, if there are any skin changes, rough skin, vitamin A deficiency, easily bruising. All these is a nutritional focused physical exam that would direct you to whether this child is having other deficiencies, a hidden hunger, or maybe we're just missing a heart murmur or a hepatomegaly or something that we missed in the clinical exam that would explain the child growth abnormality. So the lab is as appropriate. We order the lab. The basic lab is we order a CBC for the children, a stool, urine analysis, CRP, and ESR. And where the history directs me, and where the clinical exam directs me, I would order further lab. Maybe I would suspect cystic fibrosis. I would order a sweat chloride test. Maybe I would have celiac serology, because if I'm having weight and height problems, I should screen for celiac, especially in our population. Maybe I will need to, this child has weight, height, and head circumference affected. So I would send him for chromosomal testing or for a geneticist. So as the history and medical exam directs me, I would order the lab. So there is no routine lab measurement. How to put the child back on track to establish optimal growth velocity while supporting the plan of care is to improve the energy and nutrient intake if he's not taking enough, promote weight and height gain, give the child a chance to give him a good nutrition plan covering all his calories and proteins, and wait for the catch-up. And we'll know what is the catch-up, correct nutritional deficiencies, because sometimes you give him an appropriate plan with good calories and proteins, and the child is not gaining height, he's not gaining weight. Take care of the type of nutrients. Sometimes they lack the zinc. Maybe they need a boost of zinc. They have zinc deficiency, they have iron deficiency. So this would affect their growth potential, and support the parents, of course. When you are putting the calories, calculating the calories according to the needs, and calculating the catch-up calories they need if the child is falling in the weight, please make sure that the proteins would compromise around 15% of the total calories. So it's not just calories, it's calories and proteins. And if you fail to put a nutrition plan with these percentages, give the child an oral nutritional supplements that would be complete regarding the ratio of the protein to calorie. So we can do the plan with regular feeding, frequent snacks, energy-dense food diversity. If not enough, provide oral nutritional supplement for the child. And take care of the nutrients, especially type 2 nutrients, because they are likely to influence the length and the growth, especially the proteins, the zinc, potassium, and sodium. Take care of them in children with congenital heart diseases and they are on diuretics, for example. Take care of children on steroids. All these would have affection of growth, and we have to provide them with what is enough for them to provide optimum growth. Type 1 nutrients, they are responsible for the biochemical functions. They have characteristic physical sign, and they unlikely to influence in length growth, but they can influence the weight because they affect a lot the metabolism and the appetite of the children, like the B complex and the iron. So this is the take-home message for today. This is an algorithm that is done by the Italian group, and it is a consensus and a guideline later on about how to approach a child when you are monitoring the child and he deviates from the norm. So if he's having problems with the weight, revise the inadequate caloric intake, search for the deficit and try to replenish this deficit. If he's having repetitive vomiting or regurg, refer to a gastroenterologist. And they have the first level, observe the meal, take a 3-day food diary, do urine analysis or urine culture. Second level, refer to GI consultation. So if not, he's not having inadequate nutrition absorption, suspect allergy, suspect celiac. These are the main stars in the malabsorption: cystic fibrosis, pancreatic insufficiency, and chronic cholestasis, and order first level investigation. If it's increased metabolism and it's mainly inflammatory or chronic inflammation or chronic infections, order the first level, and you may order later on markers, inflammatory markers. So if he's having weight faltering with length or head circumference faltering, weight plus length, think endocrinal causes. If he's having with head circumference, weight with head circumference, think torsion infections, cerebral anomalies, or syndromes. If he's having first head circumference is not growing properly, we have to exclude, of course, torsion and cerebral anomalies and genetic microcephalus. And if the length faltered first and the height is affected more than the weight, think endocrinal causes, think syndromic or bone disease. And accordingly, you will have to order the first line of bone profile, parathyroid hormone, and later on hormonal profiles. So to end this, please, the take-home message is we should monitor the growth. Normal growth is mandate for all our children. Children have a short time to grow and a lifetime to live with the results. The results are in your hands. Proper growth monitoring is a mandate. Follow the ladder of the pediatric nutrition assessment. If growth is not optimum, please stop and reassess your child. And thank you. And thank you, Dr. Sam.
Thank you. Thank you very much, Professor Yasmin. Thank you very much indeed. Your presentation was very illustrative. You made a lot of landmarks. Dr. Ramona Mamdouh mentioned that you made it very clear that growth hormone stimulation test is not the first step in diagnosing short stature or stunted growth.
It is never, Dr. Sam. It is never the first step.
She was happy.
So we have to do a lot of assessment before even ordering the basic lab.
Yes. Okay. Thank you very much indeed.
Thank you.